Hey guys, and welcome to our Exam 5 review for lecture. So in this, I'm going to use the review guide as a backbone, and then I'm also going to show you some key highlight information as well as where to find the information. So majority of this information can be found in our lecture slides, but then also don't forget to look at those supplementary materials that are also posted on Canvas. So let's go ahead and get started. We're just going to go chronologically. We're going to start with chapter 22. So the first one is talking about the different types of diarrheas. So different types of diarrheas can be found, like I said, in our chapter 22, and it can be found found on slide 6. So I do want you to know what each of them entails, as well as some examples that can be a hallmark indicator for certain diseases. So such as with the inflammatory diarrhea, that's primarily a hallmark of Shigella or Salmonella. And then motility related diarrhea is often associated with like toxin and the rotavirus. So I'm not going to go over each of them because you can pause the video and read, but I will focus more on the diseases when we get there. So then it talks about the hepatitis serological results. So that goes over, let me find the table. So that goes over this table. So if I were to give you these results right here, I would want you to be able to tell me what does that mean. So let's do the third one. So the third one shows, let me make this slide bigger. So the third one shows a positive, 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 and negative results. So a positive, 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 negative results means that you have been acutely infected. So that is what I would want you to be able to tell me based on those results in terms of hepatitis. So that is what number 2 goes over. The third one goes over the different characteristics of these following diseases, and all these diseases are found within the lecture. So I'm going to just click through each of them and point out the hallmarks for each. So let's go ahead and just start all over. So right here. So with the differences between gingivitis and periodontal disease, gingivitis just means inflammation of the gums, whereas periodontal, this specifically has to do with bleeding of the gums as compared to just inflammation. And a lot of times with periodontal diseases, that can actually lead to heart disease as well. That's the big thing. Let's talk about oral thrush. So oral thrush is a fungal infection. It's commonly caused by Candida, and it is very common in newborns because they don't have their robust flora yet, as well as it is very common for patients who are taking broad spectrum antibiotics to develop. So the big thing with oral thrush is a white mucosa, cottage cheese, milky appearance. It's very, very common, easily treatable. You just treat it with some antifungals and you're good to go. Or a lot of times it'll self-resolve. Okie dokie. Let me go back to the list. The rota. Okay, so rotavirus. So the difference between rota and norovirus, the big thing is the types of diarrhea and how quickly they onset. So with the rotavirus, there's a toxin being produced, and there's hypermotility within the intestinal tract. There is a vaccine for rotavirus as compared for the norovirus. There's no vaccine, and the symptoms normally onset very quickly, and they normally only last for about 12 to 24 hours, whereas the rotavirus is normally 2 days, but it is also self-limiting as well. And then the norovirus, a lot of times that will happen on cruise ships, whereas rotavirus is more common among children. Okay. So we have the peptic ulcers, E. coli, shigellosis. Okay. Okay, so peptic ulcers. So peptic ulcers is caused by H. pylori. Depending on how severe the peptic ulcer is, a lot of times you'll need um, antimicrobials. Um, but there are some times where it can be self-limiting depending on how severe it is. So if it's just the start of an ulcer, sometimes you can just do supportive care, and then you can actually reintroduce good bacteria, and that can also aid in healing. But if it is a severe ulcer, then you do need to take some antibiotics to help. And then with peptic ulcers, this is the one where you can do the urea breath test. So that is really the only one where you'll do the urea breath test is in terms of peptic ulcers. And then also H. pylori is the only bacteria that we're going to talk about, and it is associated with peptic ulcers. Okay, now with all the E. coli, gastroenteritis, so these are the three that I want you to know, and I want you to know the differences between each. So the first one is the ETEC. So this is the one where a toxin is produced, and it specifically causes secretory and watery diarrhea. Whereas the EIEC only causes um, bloody diarrhea. So it's very closely similar to a Shigella infection, but I will point out what the difference is between Shigella and the E. coli one, but they present the same. And then with the EHEC, this one specifically produces a Shiga toxin. As compared to the ETEC, this one has the labial toxin. The EHEC also does cause bloody diarrhea, and this one is actually associated with an animal reservoir, whereas the other two are not associated with animal reservoirs. I believe that's the big picture of those guys. So then the difference between the EIEC and Shigella is the fact of the how it's born. So meaning how is it transmitted? So E. coli can also be transmitted through contaminated food and water, but specifically with shigellosis, it's strictly through transmission between humans via contaminated food or water or the oral fecal route. And then also how they present is slightly different. So with shigellosis, it will have abdominal cramping, severe high fever, loss of appetite, and bloody diarrhea sometimes. Whereas the EIEC, it generally will only cause bloody diarrhea. There's normally there might be other symptoms, but not as severe as shigellosis. Okay, so next we have typhoid fever. Typhoid fever. Typhoid fever. Oh, just kidding. So, salmonellosis. So, typhoid fever is one clinical presentation of salmonella infection. So, with typhoid fever, it has no animal reservoir, meaning that it doesn't reside in humans. It's only been documented in has no like other reservoir, so meaning that it's only been documented in human disease, not animal disease. So it's associated with poor food preparation, so meaning that you primarily get it through contaminated food, and then you'll have fevers, and then you'll have diarrhea for about 2 to 3 weeks. Whereas another clinical presentation of salmonella infection is enterocolitis. So this is associated with animal contact, specifically with reptiles and poultry. It is a short-term illness, so it only lasts for about 2 days or so. But as compared to typhoid fever and enterocolitis is self-limiting, meaning that you just do supportive care, so like rehydration, small quantity of foods, and then you let it pass. Whereas typhoid fever, you do need to have medication treatment, because a lot of times it can actually result in death because of severe dehydration, and then as well as the enterotoxin and endotoxin being produced by the Salmonella species, by specifically Salmonella typhi. Okay, so that's Salmonella. So what's next? We have cholera and then Campylobacter. Okay, so let's talk about cholera. So cholera is specifically caused by Vibrio cholera. So it is a gram-negative bacteria that has a single flagellum, and it is transmitted via contaminated water. So you ingest contaminated water, and then with cholera, it does produce severe watery diarrhea. That's actually why these are called cholera beds, because unfortunately a patient, if they do have it, a lot of times they can't get up quick enough to relieve themselves, and they can't hold it in because it is water, it's not solid. So it is non-invasive, so that means that there is essentially no fever and no bloody stools. So the big hallmark of cholera is that watery diarrhea, but there is some strands of cholera that does produce a toxin, and then in that case, if a toxin is produced, then it causes a different type of diarrhea, which is the secretory diarrhea. And then there is the non-cholera vibrio. So this is associated with seafood, and then a lot of times it is present in wound. So meaning that if you have a wound and then you come in contact with contaminated seafood, or you're in the coastal area, then you have the potential of getting non-cholera vibrio. But primarily focus on the standard cholera, which is the watery diarrhea, or the secretory diarrhea, and what's the difference between the two. So with the secretory diarrhea, if that's the hallmark that is being presented, then that's because a toxin is being produced. Okay, so that's pretty much cholera. Now let's talk about Campylobacter enterocolitis. So Campylobacter enterocolitis, this is the number one cause of diarrhea. It is commonly found in contaminated food products, specifically cattle and poultry. So what will happen is that the food will be handled incorrectly, or you'll eat it undercooked, primarily with chicken in terms of undercooked meat, or through unpasteurized milk from cattle. It is self-limiting, so meaning that you just do supportive care, you let it run through your system. But if you have an immunocompromised patient, then they are at risk for disseminating diseases, specifically in terms of their pancreas, gallbladder, or heart muscles being affected. And then sometimes, very, very rarely, it has been documented to cause the autoimmune disease, the Guillain-Barré syndrome that we talked about like 3 chapters ago. But if that does happen, if they are developing a secondary or disseminated disease, a lot of times they'll have numbness and tingling in their extremities, they'll have muscle weakness, they'll have difficulty speaking, chewing, and swallowing, and then they will have back pain and inability to move their eyes. But that's only if they're getting a secondary infection or secondary disease. Now, if they're just having the primary one, then they're just going to have some diarrhea, maybe even some nausea, and then general weakness because they are flushing the bacteria out, essentially. So, but the symptoms below are associated with a secondary infection or a disseminated disease. Okie dokie. So, let's talk about listeriosis. So, listeriosis. So, listeriosis is associated primarily with dairy products. Whenever the dairy product is unpasteurized, meaning that it doesn't go through the essentially decontaminated process. So what will happen is that if a healthy patient, so like the general population, does get sick, it'll just cause some gastroenteritis. Um, you normally don't um, need medication for it, but sometimes you will, especially if you have an immunocompromised patient. So if you have an immunocompromised patient, then they can experience a disseminated infection of other organs, or even experience sepsis. So at that case, you definitely want to treat them with some medications and then supportive care, replenishing all of their fluids. So with listeriosis, it can be very, very deadly. So he can cause a lot of issues. The way that he does cause issue is the fact that he can live with inside our macrophages, and that is how he can survive. So listeriosis, that's a hallmark of him. So the fact that he can live inside macrophages, that's kind of a new characteristic that we've talked about. And then also, listeriosis can actually undergo vertical transmission, meaning that it can be passed from mother to fetus. So that's another thing that's very interesting about him. Okay, so next we are going to talk about C. diff. So this is very, very common. You will see this in your patients. So C. diff is commonly associated with chronic antibiotic use. So C. diff is a bacteria, and it will cause infection. Depending on where it causes an infection is how you will categorize it. So if it causes infection in the colon only, then it's known as pseudomembranous colitis. Or if it's of the colon as well as the small intestine, then it's pseudomembranous enterocolitis. But either way, no matter where the infection occurs, it will present the same. So it will present with diarrhea, pain, and then also primarily pain in the abdominal region. So it's normally a nosocomial infection due to like improper cleaning or disinfecting of the equipment, but it can be acquired in the community or because somebody has excessive antibiotic use. So common treatment is vancomycin or omeprazole, but there have been documentations that a fecal transplant is promising. So essentially with the fecal transplant, you are introducing good bacteria in order to keep the C. diff under control. So that's pretty much all I'm going to say actually about fecal transplants. But you can treat it with antibiotics, but sometimes antibiotics can be very hard on your patient, especially vancomycin. It can have very strong side effects. So with the fecal transplant, there's minimal side effects, and it's also introducing good flora to your patient. Okay, what's next? So we're going to talk about staph food poisoning real quick. So with Staphylococcus food poisoning, it's actually not the bacteria that is causing any harm because of the fact that it doesn't live inside the intestinal environment very easily. But what can live inside the intestinal environment very easily is the toxin. So what will happen is that actually food is going to be contaminated with the toxin, making the food intoxicated. And then even though you prep the food correctly, that toxin is very, very heat stable. So meaning just because you cook your food properly, you may have killed the staph, but you did not kill the toxin. So you'll ingest that endotoxin, and then that toxin will induce a fever. And then a lot of times in immunosuppressive patients, that can actually cause more severe effects. So normally if that does happen, then you'll have symptoms that arise within 4-ish hours. And then depending on how immunocompromised your patient is will determine treatment plan. So you can treat with the antitoxin, and then you can also provide supportive care for the fever. Okay, so now let's talk about parasitic infections real quick. So the first one we're going to talk about is a flagellum protozoa. So he causes diarrhea worldwide. What will happen with him is that you will ingest contaminated water with fecal matter that actually has the parasite eggs inside, and then you will have some diarrhea, and then what will happen is that you'll go to the doctor because you're having a lot of diarrhea. They may ask for a stool sample, and then in there, then they'll diagnose, because they will see some protozoan cyst in there, and then you'll treat with some omeprazole and then also some antiparasitics, and then you're good to go. So with this one, you don't really have a lot of symptoms. Probably the most symptoms that you'll get is the diarrhea, and even then you may not even have it. So it doesn't really present very well. Okay. Okay, we're gonna talk about tapeworm and then ascars. Okay, so tapeworms. So with tapeworms, I just want you to know how does he look, and then also how does he kind of reproduce and continue to infect. So tapeworms are flat, they're elongated, and they are segmented, meaning that they are essentially a long string with building blocks put together. And what they do is that they will absorb food and pretty much any nutrients from their host in the intestinal tract. And the way that they actually reproduce is the fact that they have both male and female within one segment. So what will happen is that within that segment, fertilization will happen, and then they'll break off, producing more tapeworm in the patient. So here's a basic life cycle of it. So what will happen is that eggs, they'll pass outside of the host, and then what will happen is that another host will ingest those eggs, and then those eggs will eventually mature, turn into larvae and cyst, and then from there the host will have an adult tapeworm. Tapeworms primarily reside within the small intestines, although they have been documented in other parts of the intestinal tract, but primarily the small intestines. Depending on how severe the case of tapeworm is, will determine how to get the tapeworm out. So if it's just a mild case, sometimes antiparasitic, so dewormer, will flush out the parasite, but there are times where sometimes you actually have to physically go in and remove it. And I do have some videos about these parasite infections. Definitely take a look at them. They are pretty cool, but just fair warning, they can be kind of graphic. But I think y'all can handle it. You're going to be nursing students. So let's talk about our last parasite real quick. And these are Ascariasis, I believe that's how you say it. These are the most common worm infections that you may see. They are generally diagnosed by self, because what will happen is that these worms, they will emerge for air, and then at that time point you'll see it either coming out of your anus, your nose, or mouth. And then also that's actually how you get reinfected. Is what will happen is that these the worms, they'll come out, and then like while you're sleeping or something, you'll unconsciously scratch yourself, and then you will actually re-ingest the eggs. Primarily if you like scratch your bum, because the eggs they do reside in fecal matter primarily, so you might actually scratch your bum, and then you'll have fecal matter and eggs on your hands without knowing it while you're sleeping, and then you'll scratch your face, scratch your eyes, or touch your mouth or something, and then you actually re-ingest, and then you're just constantly reinfecting yourself. But what will happen is that after you ingest the eggs, they will hatch inside the upper intestinal area, and then they'll continue to mature, and then they'll migrate outward. They'll migrate primarily through the lungs, and then to the throat, and then even further down the intestinal tract. So, depending on how severe the infestation is, will determine treatment. So, if the doctors feel that it's not that severe, then you might just be treated with some dewormer, pretty much. Or they may actually have to surgically go in and remove it. And that will, if you want to see a procedure of that, you can watch that video right here. It is very graphic, just fair warning, but it's definitely a procedure that um, can occur if you have a severe infestation of worms. Okay, so I believe with that, that'll wrap up our chapter 22. So let's go ahead and, talk about chapter 23. Most of chapter 23 we've actually talked about quite a bit throughout the term, so I'm going to go very, very quickly in chapter 23. So with chapter 23, we're going to talk about differences of UTIs. So the differences between UTIs. Where's that slide? Right here. So there are two different types of UTIs. There is the cystis, which is the inflammation of the urinary bladder only, or you have the inflammation infection of the kidney. So it's pretty much the upper and lower part of the urinary tract. So the lower part of the urinary tract is going to be the urethra and the bladder, and then the upper respiratory tract is going to be your ureters and your kidneys, essentially. So that's a very broad separation, but for us, that's how we're going to divide it. Okay, so I went over the two differences, so I do want you to know the differences between that. And then also I want you to know how to read a urine analysis, a very, very basic urine analysis. So with that, I might throw up something like this on the exam. So with the urine analysis, I want you to be able to tell me which side is normal and which side is not normal. And then based on the abnormalities, what can you conclude? Can you conclude that there is a infection or not an infection? So an urinalysis, on the one I'm going to give you, the leftmost side is going to be considered normal, and then further away towards the right is going to be considered abnormal. So generally what will happen, the big tall tale signs of a urine analysis that will determine if there are an infection going on is the presence of excessive nitrates. Not nitrates, I'm sorry, nitrites. So we have nitrates, but what happens is that the bacteria will convert them into nitrites. So if we have excessive nitrites, then a lot of times that can indicate that we have excessive amount of bacteria, which is not what we want. And then also urinalysis, you can go off a base of color, and then also you can do a microscope exam, but with microscopic exams, that's primarily done for like STD testing, not so much for UTI testing. But you can do it for UTIs, it's just not as common. At least in my experience, it wasn't that common. We primarily did STD testing with that, and primarily it was chlamydia and gonorrhea. But with a urine analysis, I want you just to be able to tell me, based off of these results, what is that normal, and from that, can you determine if there is if there's bacteria present or not present. Pretty much it. Okay, so let's click through some of these STDs. So we're going to start with genital warts, it looks like. So genital warts. Okay, so genital warts, we've talked a lot about him before, but just some big picture. He is caused by the HPV virus. There are numerous different subtypes of him, but the most common one is 6, 11, 16, and 18. 6 and 11, they cause majority of the genital warts cases, and they are not associated with cervical cancer, although that does not mean that they can't cause cervical cancer, but the two main types that have been highly linked to cervical cancer rates is 16 and 18. But in order to prevent that, there is actually an HPV vaccine specifically against these subtypes 6, 11, 16, and 18. And with that vaccine coming out, it has drastically reduced the rate of cervical cancer, um, very much greatly. If a patient does have genital warts, a lot of times they will just have these cauliflower skin lesions. A lot of times they're soft to the touch, but there are sometimes they can be very painful for the patient. They can be very tender, very itchy. A lot of times patients will opt to have them removed, and then just because they have them removed does not mean they can't come back. So depending on how severe or how many of the cauliflowers are present will determine which route they're going to take, whether it be freeze off or actual surgical removing, depending on how big they are. That's also up to the doctor's preference. So some dermatologists, they prefer doing the freezing off because it's less invasive and harsh, but there are times where sometimes surgical removal needs to happen, especially if it's a severe wart. Okay, so genital herpes. So genital herpes is caused by herpes simplex 1 and 2. Herpes simplex 1 is associated with oral and genital, whereas herpes simplex 2 is solely genital. With signs and symptoms, they are the worst at the first time of being infected. So they will have lesions, blisters, a burning, itching sensation, and then sometimes even painful urination depending on where the lesions are located. And then also a lot of times patients will exhibit severe muscle aches and fever, and with the headaches that can also lead to nausea. After the first infection, the patient may have reoccurring infections, but that kind of just depends on the patient. Some may never have another outbreak, so another infection. Some may have reoccurring infections. It really just depends on patient, and then also depends on external factors such as like stress, emotional health as well can definitely cause a outbreak once again. But generally the first infection tends to be the worst of them all. While the patient is not having an active outbreak or active infection, they are not contagious. The patient is only contagious during an infection, and then also 7 to 10 days following after the last symptom has been documented. So meaning 10 days after all signs and symptoms resolve, that's the patient is also still considered contagious. That phase is called the asymptomatic shedding. So that all the infected skin in that area still has virions or viral progeny, essentially, that can be still transmitted to partner. So it's always good to advise your patient to not have sexual activity during an outbreak, and then also 10 days after signs and symptoms have resolved. But while the patient is in between outbreaks, they can technically still pass it on, but it's almost completely unlikely. It's a very, very, very small percentage of which they can transmit. And during that time period, they're also in a latent period, meaning that the virus has retreated to the neurons at the base of the spine, and they're just essentially chilling out there. They're not causing any infection. Now, if a patient does have another episode, they'll have the same signs and symptoms, but generally less severe. And then also sometimes the outbreak does not last as long. Depending on how often the patient experiences outbreaks will determine treatment plan. So sometimes patients, they'll just ride it out because normally it is self-resolving, but there are some times where the doctor may prescribe some antivirals for them to have pretty much as needed, so PRN, and then they can take it as directed. And then also, if a patient has a lot of reoccurring episodes, they can also take antivirals daily as a prophylactic treatment. So with the prophylactic treatment, that also minimizes reoccurrence, transmission, and then also how long the outbreak can occur. So also with genital herpes, real quick, there is something called neonate herpes. So this happens whenever the baby gets infected because of mom. Um, so a lot of times, what will happen is that the mother will have genital herpes. So if the mother gets her first outbreak while she's pregnant, then the transmitting it to fetus is a lot more higher as compared to a mother that has been living with genital herpes. Um, a lot of times, neonate herpes will happen during vaginal delivery. With neonate herpes, it can be very detrimental to baby because of baby isn't protected. It doesn't have a robust immune system, and it can also disseminate. And then if it goes untreated, a lot of times it has a high mortality rate. But the general rule for mothers that have genital herpes, they can give a vaginal delivery without complications, almost normally, um, assuming that there is no active lesions or any underlying symptoms, as well as the herpes culture was negative of the mother's cervix. Um, but if the mother is experiencing an episode or just experienced an episode, a lot of times a cesarean delivery will be preferred in order to preserve the treatment. I'm not treatment of mother. Preservation of the fetus. And then also, a mother may even undergo some antiviral prophylactic suppressive treatment during her last trimester in order to minimize the risk of an episode, because labor and pregnancy is very, very harsh on the body, and that can actually reactivate the herpes virus. Okay, so now we're going to talk about HIV. So HIV is a RNA based virus. It is transmitted sexually, so through vaginal, oral, or anal sex, or through direct contact of contaminated bodily fluid. So what happens is that HIV will infect the blood. Specifically, it will go and, I'm sorry, it doesn't infect the blood. It infects T cells, primarily the CD4 T cells, and it will replicate very, very rapidly. HIV has multiple stages. So as HIV progresses in these 4 stages, these are in chronological stages. As it progresses, the viral load, meaning the amount of HIV present, will increase, and then with that, CD4 count will decrease. So as CD4 cell count decreases, once it gets to a certain number, the patient is considered in the AIDS stage, and that is whenever CD4 count is at 200 or less. But before that, he is in the primary stage, which is normally where a patient is asymptomatic. They don't have any signs or symptoms, but they could exhibit some fever and rash. Kind of just depends, but for the most part, people are asymptomatic. Then you have the clinical latency. This is where T cell counts will slowly start declining, and that's pretty much the only sign and symptom. Other than that, there's nothing else. And then you actually have the early symptomatic diseases, which is where you're actually starting to have secondary infections because your CD T cell count is getting lower, and with that, that's making you more prone to other infections such as oral thrush, reoccurring vaginal infection, shingles if a patient has had chickenpox in the past, and then as well as any other secondary infections. And then once the patient is in the AIDS stage of HIV infection, like I said, their CD count are lower than 200, and a lot of times these patients will acquire pneumonia, and unfortunately a lot of times pneumonia is what will kill these patients, unfortunately. But there has been a lot of turnout with HIV treatment, and the most common treatment now is called HAART. So this is a combination of antiretroviral therapy. With HAART, it's extremely beneficial because what it does is that it actually stops HIV from replicating inside the blood. And with that, it reduces viral load. With reduced viral load, you actually have an increase of CD4 counts. And if you have an increase of CD4 count, a lot of times you can fight infections a lot easier, and you have less complications because of the infection. So that's definitely a huge benefit and a huge medical advantage that we have now to treat HIV. Okay, so let's talk about syphilis. So syphilis occurs in primarily 4-ish stages. It is caused by a bacteria. So what it does is that it will invade the mucosal lining and break down skin through sexual contact. So there is an incubation stage, which is roughly 1 to 2 months after contracting the disease, and this is where the organism is actually replicating, making more of itself, and spreading throughout the body. And then you have primary syphilis. So this is where you'll actually have a reaction at the infection site. So generally in the genital area, where a sore essentially will appear. It is painless, but it is hard. And then if you were to take a culture of that, you will actually see the bacteria, which is the spiral part of the bacteria. So it kind of looks like this. So all these little spirals, that is what will be present if you were to take a culture of the lesion. And then you have latent syphilis. This is where you've been living with it for several years. A lot of times symptoms are absent, but patients have reported developing a rash. But that's pretty much it. And then there's tertiary syphilis. This is where the disease has, for the most part, run its course. And unfortunately, at this time point, the patient will exhibit some cardiovascular issues and some neurological issues. So with neurological issues, there can be a decline in cognition, which can develop dementia, so a lot of confusion. And then as well as actually temperament changes, such as like severe aggression or actually severe depression. So kind of like the emotional extremes. And then also the skin is starting to be affected, and gunums will start being produced, which is where soft tissue is affected. So you will get these sores where the tissue is being degraded. So it's not always on the skin. It can also happen on organs as well as bones. And then unfortunately, at this time point, the patient can die from a syphilis infection. Okay. Then we're going to talk about gonorrhea. Okay, so gonorrhea, also known as the clap. So it is produced by N. gonorrhoeae. So with gonorrhea, symptoms, they normally occur within a week after becoming infected, but it has been documented to take up to a month. Most men will actually exhibit symptoms, whereas women normally do not. So with men, if they have gonorrhea, they will experience a yellow discharge from their penis. And then sometimes if it continues, or if it's a severe infection of gonorrhea, then they can actually have swelling of the testicles, and that can be very painful for the patient. You can treat it with antibiotics, but gonorrhea has been showing some antibiotic resistance. So it is starting to get a little bit more difficult to treat, but if you have the non-antibiotic resistant strand, antibiotics will clear it up, And then that goes with women too. Women can also be treated with antibiotics, but generally they actually don't exhibit any symptoms. But if symptoms are present, a lot of times they have painful urination and then vaginal discharge, kind of like men. But with women, though, if it continues to go untreated, she can actually develop something called PID, which is a severe inflammation of pelvic organs such as the uterus and the fallopian tubes, and PID can actually lead to fertility issues. So definitely make sure you are being safe sex conscious. Okay, I believe those were the main ones. Oh, non-gonorrheal, sorry. Non-gonorrheal. I don't remember even talking about that. So actually, probably not even non-gonorrheal, but chlamydia. Definitely did talk about chlamydia. So chlamydia is also a bacteria, STD. So there are different types of non-gon. Oh, there it is, non-gonorrheal. So that's chlamydia. So chlamydia is probably the most documented of all STDs. But actually, a lot of people show no symptoms. They actually don't even know that they are infected. But if um, one does notice something, a lot of times it's discharge. So, in order to confirm which bacteria is causing this STD, a PCR will confirm it. So, just like how gonorrhea presents with vaginal discharge, so does chlamydia. So, in order to differentiate between the two, a PCR is done, which is just a diagnostic testing in order to determine which bacteria it is. Okay, I believe that's all I'm going to talk about. There are other diseases, but definitely those are the big ones. And then don't forget to look at vaginosis. So vaginosis, the big difference between the vaginosis is clinical presentation. So clinical presentation between bacterial and fungal vaginosis is with bacterial vaginosis there is an odor, whereas with fungal there is no odor, but discharge is present in both. And vaginosis is pretty much a woman disease, although men can get yeast infections. They can. It's just more difficult for them to do it based on their anatomy. So that's the big difference between bacterial and fungal vaginosis. Okay, so with that, that's going to wrap up our chapter 23. So let's talk about chapter 24 relatively quickly. I'm just going to point out the hallmarks of them. With the first one, where it says the spinal fluid for patients with bacterial and viral infections. So the difference between spinal fluids for bacterial and viral neurological infections is that with bacterial spinal fluid is that whenever you collect it, it will be cloudy, whereas with viral, it will be clear. And then also with bacterial infections, it is generally considered a medical emergency, and you need to treat that patient very quickly because a lot of times it can result in death. Whereas viral, it is not considered a medical emergency, and a lot of times it is self-resolving, so you can just provide supportive care. Okay, so with that, let's go ahead and talk about those diseases and the hallmarks of them, and then that will wrap up our review. So let's talk about rabies. So rabies itself is a relatively nasty infection. So what happens with rabies is that there's three presentations of it. There's the furious one, which is where the infected is extremely aggressive and may even bite, and hydrophobia is present. So hydrophobia is where they quote unquote have a fear of water, although it's not an actual fear, what it is that the infected unfortunately cannot swallow any fluids. So it makes them actually gag it. It makes them gag and then also even actually vomit it up, which will actually produce that foaminess that we have heard so much about. And then we have the paralytic. This is where the patient has general weakness of limbs, so they have a hard time picking up any limbs, movement, and then they are unaware of their surroundings, so they're very confused. And then there's atypical, which is where there's neuropathic pain within the extremities, and a lot of times with that there is abnormal movement in the limb that is affected. So if you got like bit in your leg, that leg that was bit, you'll actually have spastic movement, and then with that that is showing signs of your brainstem being damaged. And unfortunately, all of these presentations will lead to coma and death. But there is a vaccine against rabies. Most people don't get the vaccine unless it's an occupational hazard where they're going to be exposed to wildlife. So, such as like vets or like wildlife management, park rangers. Those are people that will most likely get the vaccine, but most of us actually don't get the vaccine for rabies. What will happen is that you will get treated after being exposed. So, such as after a like a bite wound from a dog or something. It's probably the most common that will happen. So what will happen is that you will get bit by a quote unquote wild animal, and then you'll go seek medical treatment. And then since it's an animal bite bite wound, the doctor will tell you like you need to get the rabies treatment, which is the vaccine, plus the immunoglobulin inside the vaccine. Now, just because you had an animal bite does not mean you have rabies. It's more or less as a prophylactic treatment. Although, unless you know the animal did have rabies, then you definitely want to get that treated. I think that's all I'm going to say about rabies. There is a video to show clinical presentations for your pleasure. Just fair warning, the video is pretty graphic, but it does show a very authentic presentation of rabies. And then yeah, I think that's it. That's all I wanted to say. Sorry guys, I keep spacing out. Okay, so with the mosquito-borne encephalitis, I really just want you to know how it's transmitted. I'm not really too concerned about these two, but with both of them, they are transmitted via bird population. But with the Eastern Asquarian, this one involves mosquitoes and horses. They are very rare. It's not very common. Both of them will result in encephalitis, but the EEE has a higher fatality or mortality rate as compared to West Nile encephalitis, whereas West Nile encephalitis, most people don't develop disease. And if they do get sick, then a lot of times it's just flu-like. Okay. Okay, so then polio. So with polio, mellitus. Oh, sorry guys, I'm butchering these names. It's very, very contagious. It is transmitted person to person. Most people are asymptomatic, meaning that they don't show anything, but there are some cases where it's a non-paralytic form, meaning that there is no paralysis present, but they will have a fever, muscle aches, and then if it doesn't self-resolve, then meningitis is a possibility. Now, there are some times where patients are symptomatic and they will actually develop paralysis, and that paralysis will actually start destroying motor neurons and can actually lead to long-term deficits, so disabilities. Okay, So with that, I believe our next one is bacterial meningitis. Yes, so meningococcal meningitis. So meningococcal meningitis, this is a medical emergency because it can lead to death. With bacterial meningitis, it does spread person to person or through contact with contaminated fomites, or actually through somebody who is sick sneezing and you inhaling those aerosols. What makes meningitis a very good pathogen is the fact that he does have that type 4 pili that does aid in adhesion. And then with his adhesion ability, he's actually able to pass through the blood-brain barrier. And with that, he can be very deadly because he can produce an endotoxin. Not all strands will produce an endotoxin, but a good chunk of them do. And then if an endotoxin is produced, then you'll get like these purple like spots or bruises on your patient. But there is a vaccine, so yay, get vaccinated, guys. But since y'all all came into college, I think everybody was required to get one. But you generally will offer this to the school-aged population. One, because a lot of times people will share stuff, and then also because it's close quarters, because of the fact that it can be, I don't want to say airborne, but it can be inhaled. So, but bacterial meningitis is a medical emergency, and then also with diagnosing, the cerebral spinal fluid will be cloudy in a spinal tap, whereas viral is clear. Okie dokie. I think with that, we're going to talk about botulism, tetanus, and prion. Okay, so botulism. So botulism is caused by the Clostridium species. It is considered a foodborne pathogen, so it is a serious illness. Death can occur. It is caused because a toxin is produced, and that toxin will cause paralysis. And the paralysis generally starts in the face, and it can spread to the limbs. At that point, if it's not caught in time, it can actually start affecting breathing muscles. And if breathing muscles become a factor, then respiratory failure can actually occur. But at that point, if the patient is being treated but still has respiratory issues, then they may actually put the patient on a ventilator. In order to treat this, the doctor will give an antitoxin. The antitoxin doesn't stop the pathogen. What it does is that it will stop the new toxin from causing issues. It doesn't reverse the effect of what happens, but what will happen is that your body will slowly start recovering because there is less and less toxin being produced because of the antitoxin. Now, in order to prevent this, since it is primarily foodborne, you want to make sure that if you're like canning your own food or buying personally canned food, that it is prepared correctly. Either the food is contained in an acidic environment, or during the canning process, it is overly heated in order to prevent bacteria from continuing to grow, as well as adding nitrites in order to prevent the sporing of botulism, of Clostridium, not of botulism, of Clostridium. Okay, I do have a video embedded, so definitely take a look at that in order to help with studying. So let's talk about tetanus, and then we will talk about some prions, and then that will wrap up our review video. So tetanus is kind of similar to botulism in the context that they both produce a toxin. So tetanus is also caused by a Clostridium species. This is when the bacteria invades your body, produces a toxin that causes very, very intense muscle contraction. Generally, the first muscle that will be affected is your jaw, so that's why it's also called locked jaw. So this is where the muscles in your neck and your jaw will lock up, and it's very, very difficult to open or swallow. Tetanus is a medical emergency. and the doctor will treat you a lot of times with the antitoxin as well, with the immunoglobulin inside of it. And then um, in order to prevent tetanus, we actually have a vaccine against it. Tetanus is really the only vaccine that requires a booster. There are kind of other ones, but mainly tetanus is the big one in order to maintain your immune system to the toxin. So the best way to prevent tetanus is to be vaccinated. Okay, so with that, let's talk about a prion disease. So with prions, I really just want you to know what happens and then what's the effect of what is happening. So with prion diseases, it's generally associated with cannibalism. Um, I'm not going to say that it doesn't occur because it does. It normally doesn't occur stateside though, although there have been documentations of it. You can get a prion disease from contaminating meat. You don't have to eat a person. But what will happen is that if a prion disease is contracted, is that it will cause misfolding of your proteins. And with those proteins being misfolded and not in their original conformation, it will cause the proteins to not function. And then with their structure being misformed, it will start producing these amyloids, these structures, these accumulated structures that actually lead to cognitive decline, neurological decline, motor decline, and then eventually actually death. So that's the big picture of what I want you to get from prions. There is this video that does show clinical presentation of it, so definitely take a look at that. I believe with that, that's actually going to wrap up our reviews. Yep, so I'll wrap up our review session. Um, like I said, definitely take a look at those supplemental questions in order to help aid you in picking out the hallmarks from case studies so you can better identify what infection is going on or even what pathogen is actually causing the disease. So with that, I'm going to go ahead and sign off. If y'all have any questions, definitely don't hesitate to contact, and I will see y'all in class.